everybody. Welcome to iCubed this month. This is iCubed episode 26, believe it or not. I want to welcome back a guest that I had just a few months ago, and it was a wonderful visit, so therefore I asked him to come back and revisit with us again. Introduce yourself.
I am Cristian Patterson. I started here, I finished residency this last summer, started back in July, and it's a crazy place to start out right after residency. But yeah, it's been a lot of fun.
When you were here last, you were a brand new attending for about 3 months. It's been about 4 months since then. What do you think?
It's a wild place to start, but it's been good. Once again, getting more comfortable and stuff with what we see here at Baywood.
Exactly.
With the geriatric population that we see here.
That's right. Now, where did you go to medical school and undergraduate school?
I did undergrad at ASU. I did medicinal biochemistry there, and then I went to Midwestern University in Glendale. I know it's not in the Midwest, but it's the sister campus. I always have to explain this to people.
Yes.
And then I did residency at Dr. Lee's alma mater, Maricopa County in downtown Phoenix.
I'm so excited to have you with our group. So Dr. Paul Beeston is also alumnus from Maricopa, so I'm very happy to have the three of us from our residency here. Now, I heard recently that you were chief resident, were you?
Yes.
Yeah, so what were the duties for the chief resident there?
We had to meet with leadership, and my main responsibility was being in charge of our didactic conference that we did every month.
Very nice.
So we did not every month, every week. So every week we'd have a didactic conference and trying to line up speakers coming in.
That's right.
Getting residents assigned talks, getting the residents to do their talks. It was sometimes filling in when they didn't do their talks, so I did a lot of those. So.
That's right. That's actually when we first met. It's when I did my resilience talk at the alumni day last year. So, well, Cristian, we are going to just plunge right into this month's cases. So patient number one is an 85-year-old gentleman. He has a past history of prostate cancer. He comes to the emergency department with the acute, abrupt onset of dizziness and nausea while he was driving.
Oh, dizziness.
Yeah. So he manages to drive home, but he kept falling to his right when he walked into his house, right? He has no headache. He has no pain anywhere. He doesn't have any numbness, paresthesias. He does complain of being very nauseous. EMS says that at first he was really pale and diaphoretic when they found him. His blood pressure, systolic blood pressure, was about 170, and it looked like he was in slow atrial fib, and the patient has no history of atrial fib. So he gets to you. You look at his first set of vital signs. Blood pressure is 155 over 89. His heart rate is 90. His respirations are 16, room air sat 100%, and his oral temp is 36.6. His general exam, he's actually a pretty well-developed, thin-looking guy, elderly male, but he looks unwell. He looks like he doesn't feel good, right? But he's not diaphoretic now, and he keeps his eyes closed. He is awake, and he converses with you. He is oriented. His speech is clear, and he does have bilateral lateral gaze nystagmus. Any thoughts now? This is your first 2 minutes with him.
So he has nystagmus when he looks in both directions?
Bilateral, lateral gaze nystagmus.
No vertical or rotational nystagmus?
Nope, neither.
I mean, this guy is concerning for possible cerebellar stroke just because, again, he's got the ataxia.
Yep.
Falling in one direction, new onset, slow AFib. His vitals look great, which is good.
Yep.
But, and then he's got the nausea as well, which could possibly be this.
No, your thoughts are exactly mine. You know, when it comes to dizziness, ataxia always stands out for me and triggers the thought of cerebellar insult or cerebellar or midbrain etiology, because your typical vertigo is not going to cause ataxia. So yeah, we had the same thought. What other differentials? We're talking about cerebellar, but what other differential? Just thinking in terms of thinking broadly on someone who comes in dizzy, right?
So yeah, I usually kind of separate from peripheral vertigo and central vertigo. Central vertigo being something stroke in the cerebellum, or and then peripheral being usually, I kind of say inner ear type stuff.
Correct.
So labyrinthitis or BPPV or something along those lines, which is more benign, but again, sometimes it can be a little unclear which you're dealing with.
So let's talk about the next patient before we finish the first one. So the next patient, 80-year-old gentleman with a history of hypertension, hypothyroidism, BPH. He was brought in by EMS as a stroke alert. We are a stroke center. So when a patient is brought in as a stroke alert, the stroke nurses are called down to the ER, and oftentimes they're in the room before we are, right? The patient goes directly, as per protocol, the patient goes directly from Ambo Bay or the triage right into the CT scanner. Right?
And most of the time, if you want to catch him, you got to go straight to the CT scanner.
Exactly. So we get the history that he's been in his usual good state of health until suddenly, while in the bathtub, he became very, very dizzy, very weak, and he started to throw up. His wife happened to check on him. She said that he was slow to answer, that he was slurring, and he had vomited in the tub. Upon arrival to the ER, he goes directly to the CT scanner, and then he was brought over to the patient room. I hadn't seen the patient yet, and the stroke nurses were already there, talking to him, examining him. So while I walk into the room and I look at the guy, and he looks really sick. He's clammy, he's cold to touch, he's flushed in the face, and he keeps his eyes tightly closed, okay? The stroke nurse was already there, like I said, and she said, oh, he's oriented and he's not altered at all. His NIHSS is 1 for his slurring, which surprised me, honestly, because I look at this guy, he looks so sick, but she was saying he's really with it. Oh, okay. So then I'll go up to him closer and I talk to the patient a little bit. He says he is answering my question quite appropriately. He does have a very slight slur to his speech, and he does not have any pain anywhere. Headache, chest, belly, back, no pain, no neck pain, nothing, right? And I ask him, as I do many, many times, how would you describe your dizziness? Right?
Is the room spinning or are you lightheaded?
Right. And what
little both.
I know. Anyway, so he describes his dizzy feeling as, I couldn't focus too easily. So that could mean a few things, right? In my mind, it felt, maybe he had nystagmus, or maybe he had blurry vision. So then his neuro exam, he's awake, he's alert, he's oriented. He had that very, very slight slurring of speech. There was no nystagmus, either spontaneously looking forward or to the side. And he was preferred to keep his eyes closed. Okay? Thoughts on this guy?
It sounds like a similar differential.
Yeah. So, you're right. The differentials are very similar to the very first one, right? Because this guy now is looking very, very sick. He's got an abrupt onset, he said, of dizziness. He's vomiting. And that was a prominent feature on this guy, whereas the first guy, he didn't really throw up. He vomited multiple times at home. He vomited in the emergency department while I was taking care of him. So his vitals, his blood pressure is 210/76. His pulse is 68. Respirations are 20, and his room air sat is 97%. What do you think of that?
That's a little more exciting. The last guy, I think he was close to like 160, and I'm like, boring.
Right.
This guy's is a little bit more exciting. Yeah. It's above 200.
Yeah, so, with hypertension, it's always the chicken or the egg, right? So, but it's still remarkable that he was notably very, very hypertensive and looking very ill.
Yeah, this would fall in hypertensive and symptomatic.
Yeah, totally. So then let's talk about the hospital course on these two gentlemen, because they both had negative brain CTs in the ED, but they were both so sick. Obviously, I knew right off the bat they weren't going home. This was not BPPV. This was not some benign issue. I had them admitted to the neurology service. And then next day they did the MRA and MRI. They each showed an acute right superior cerebellar artery stroke.
Wow.
Yeah.
2 for 2.
It's the exact same artery that was occluded. So just really quick, this is the circle of Willis. We're not going to go through a whole lot. And I just wanted to show you that the superior cerebellar artery perfuses the brainstem, the cerebellum. And there it is, right there. All right. Dr. Patterson, what do you think? Learning focus number 1.
Oh, I'm going to have to guess what's behind door number 1. I would just say in any of these, dizzy cases,
Yeah.
I mean, we see so many of them. A lot of times I think sometimes we get jaded and like, it's just nothing, it'll go away.
That's totally
But
true.
you always have to keep this in your differential.
That's
so
right.
always try and rule out, central causes of vertigo
Right.
or
So
dizziness.
I've been listening to a couple of Oculomotor's podcasts, the EM Cast. In the past few months, he's had Dr. Danya Koja come on, who is Dr. Dizzy, he calls her affectionately. And so I was inspired by their talks because I heard and learned something I've never heard of, which was the HINTS exam.
This is a fun one.
Were you taught the HINTS in residence?
Yes, so we did learn hints. The difficult thing is when to apply hints.
Yeah.
I'm guessing we're probably going to talk about that coming up.
So because of my knowledge gap, I was so inspired by their Alma Mater's podcast to really learn about hints and about how to apply it in the dizzy patient, because we are in a geriatrics ER. We see dizzy patients all day long, just like we see chest pains all day long. And on these two patients, I did not perform hints. I had no idea what a hints exam really was, okay? So now I am bound and determined to teach you and everybody else who watches this how to perform a hints exam. So that's our learning focus number 1. So what is a hints exam, all right? So it is a 3-part oculomotor screening exam of a dizzy patient to distinguish between peripheral versus a central cause of dizziness, right? Okay, so the very original HINTS exam paper was published back in 2009 in a stroke journal. So what is the HINTS, right?
Head impulse, nystagmus, and test of skew.
Very good. So there are 3 parts to the HINTS exam, okay? It's very easy. We can all remember 3 things very easily. Head impulse, nystagmus, and the test of skew. So before we go on, though, it's really critical that we know this caveat, which is that you cannot and should not perform hints on a patient who is not dizzy when they come to the emergency department. It is only used in patients who are still dizzy. Like my 2 patients, when they came in, they were still dizzy.
So,
but I didn't know about the hints back then.
Yeah, technically, if you did the hints exam on me right now, it would be concerning for stroke.
Yes.
Because I am not dizzy.
That's
so,
right. That's right. This is a critical caveat to know. Because misapplying the HINTS exam will give you very confusing information. So I did scour the internet about HINTS exam, and I have used Dr. David Newman-Toker's website and used his videos to try to demonstrate to everybody what the HINTS exam and how to perform it. So the first part, let's learn about the first part of the HINTS, which is the head impulse test, okay? So I want you to watch and listen to his explanation because he can do it much better than I.
We'll start by asking the patient to look straight at our nose and then let them know, warn them that we're going to be moving their head from side to side, first slowly and then a little bit more quickly in a moment. Just keep looking straight here at my nose as we go. I'm going to turn your head a little more quickly. And what you can see that I'm doing is displacing the head laterally by approximately 20 degrees and rotating rapidly back to the midline. The same over to the other side, rotating rapidly back to the midline. The key to the technique of this maneuver is that it's performed with a rapid head rotation, and generally it's best performed the patient being unaware of which direction they're going. So often during the technique we'll oscillate between slow movements and fast movements, paying attention to the fast movements and sometimes changing the direction. So that the patient does not become aware of the order in which they're being tested. What you're looking for is any evidence of slippage of the eyes off of the target during the head rotation. So I'm going to place my hands gently on the side of the patient's head and warn them that I'm going to move the head from side to side. going to rotate your head slowly from side to side. You just keep looking straight at the camera. Doing a great job. And now I'm going to turn the head a little bit faster, okay? And just relax your neck. Keep looking straight at the camera. And what you'll note that I'm doing is displacing the head laterally by about 20 degrees and rotating rapidly back to the midline. Okay? Again, rotating the head approximately 20 degrees and rotating rapidly back to the midline. The key in performing this test is that during the head rotations there need to be opportunities to alternate between fast and slow, or change up the direction of the head movement so that the brainstem doesn't interpose a saccade in place of the vestibulocular reflex. If it gets too predictive, the brainstem simply creates an artificial fix for the broken vestibulocular reflex response. So typically we'll try to make the sequence more unpredictable. Just try to relax your head. And again, the eyes stay straight on target, looking straight at the camera. No refixation saccade indicates a normal response, which in the context of an acute vestibular syndrome indicates usually that the problem is a stroke rather than a vestibular neuritis.
So that's the technique, the actual physical examination technique. I want to show you an example of a patient that has a positive head impulse test. Now, I got this from Dr. Peter Johns. He's a physician, ER doctor, actually, assistant professor at the Department of Emergency Medicine in Ottawa. So here's an example of an abnormal head impulse test.
Here is an abnormal head impulse test. Notice how this man, initially you can see some nystagmus when he looks to the left beating nystagmus. Then when his head is turned to the right, you'll see the catch-up saccade. This is normal, that one. The next one will be the catch-up saccade. Did you see how there's a larger movement of the eye from the right to the back to the midline? That's an abnormal head impulse test, which is reassuring in the HINTS exam because you're showing that he has a nerve problem, probably doesn't have a brain problem. There's a catch-up saccade. He almost did it while his head was being turned, but there was an abnormal catch-up saccade. So that's reassuring HINTS exam because he has an abnormal head impulse test.
So this part is really confusing, but an abnormal or a positive head impulse means a good thing, means it's a peripheral etiology.
Yeah, so this is where if you did it on me, mine would be negative, and that would be concerning for a stroke. That's why you don't do it on patients that don't have continuous symptoms.
That's right. So remember, an abnormal head impulse test means peripheral etiology, right? That's very important here. Here's an example of a worrisome head impulse test or a normal head impulse test. Again, by Dr. Johns.
This lady who we saw earlier with the direction changing the nystagmus, she has a rock-solid head impulse test, which is worrisome because she has acute vertigo and nystagmus. We can't find a nerve problem, so she probably has a brain problem, which she did.
So we got to remember a normal or negative head impulse test means central etiology. That's very, very important to know. So that was the part one, head impulse test. Part two is nystagmus.
Next thing we're going to show is the search for nystagmus. And again, pursuing the finger from side to side, looking for evidence of breakdown of smooth pursuit, and here the smooth pursuits are normal, and evidence of nystagmus out on far lateral gaze in either direction, pausing at the extremes of gaze to make sure there's no gaze-evoked nystagmus. And again, the results are normal. Occasional refixation saccade is within normal limits, but any sustained problems with smooth pursuit or nystagmus at extremes of gaze is generally pathological.
So that was Dr. David Newman-Toker demonstrating the technique for finding nystagmus or eliciting nystagmus. So here, again with Dr. Johns' video, I was able to find examples of unidirectional nystagmus, which is that the nystagmus, the fast component goes only to one direction. And then an example of a bidirectional nystagmus patient, which is that the fast component of the nystagmus changes depending on which direction you go. So if you're looking to the right, the fast component goes to the right. If you're looking to the left, the fast component goes to the left. That's very worrisome in central etiology.
When he looks to the left, his nystagmus increases, it's left beating, and there's a rotatory component towards the left, and it increases when he looks to the left. You can see the torsional component, and when he looks to the right, it lessens, but the fast component is still towards the left. So it's unidirectional nystagmus. It doesn't change direction. In the HINTS exam, this is reassuring. Compare that to this lady, who, when she looks to the right, she has small horizontal nystagmus with the fast component to the right. I showed this short clip twice just to see the little right word beating nystagmus. And then when she moves more central and to the left, you can definitely see that her nystagmus is now beating towards the left. So she has direction changing nystagmus or bidirectional nystagmus, and that's worrisome in the HINTS exam.
So that was part 2 of the HINTS exam. And the last one, not too complicated and very brief, is the part 3 of the HINTS exam, the test of skew.
Finally, searching for evidence of skew deviation or vertical strabismus with alternate cover testing. We're going to alternately cover each eye with the patient looking at fixing an object, either the examiner's nose or in this case the camera. Just keep looking straight at the camera, and I'm going to cover each eye alternately and watch the eyes for any evidence of movement or refixation. What you can see is that the eyes stay stable. Small refixations horizontally are normal, but vertical refixations are abnormal and in the context of acute vestibular syndrome indicate skew deviation, which generally points to stroke as the cause for the symptoms.
And from Dr. Johns, again, is a patient with a positive test of skew.
In this patient, observe how when I first take away my hand from his right eye, that the right eye will go medially and upward. And then when I take my hand away from the left eye, it goes medially and downward. It gets a little less as we go along, but there's definitely some vertical skew deviation, which is worrisome in the HINTS exam. Upward and medially, downward and medially, upward again. So this abnormal vertical skew deviation is worrisome in the HINTS exam.
So then, even though the acronym HINTS has the order of exam as head impulse, nystagmus, and test of skew, but it's really recommended that you perform the nystagmus exam first because it's at least uncomfortable. And then you perform the test of skew, which is a simple test, and then the head impulse test. Now, there's caveats to doing the head impulse test, obviously, because you don't want to do it in someone who has neck pain, who can't cooperate, and those kind of common sense issues that you cannot perform a head impulse test on. Learning focus number 2. No guesses.
No guesses. I don't know.
So,
how to interpret?
How to interpret it, right? Because we can learn the physical technique, but then when you have findings, what do you make of the findings? How do you interpret those findings? And this is actually very much more complex than a short screencast can really delve into. But I'm going to try to break it down. And I found this article that Dr. Amelmep 2 was talking about, and it's very, very, very instructive. So I would highly recommend anybody who is interested in this topic to pull this one up and read through it. So Dr. Jonathan Edlow states, not all patients with acute onset severe persistent dizziness have nystagmus. I use the terms acute vestibular syndrome with nystagmus and acute vestibular syndrome without nystagmus. The distinction is important because the diagnostic approach differs somewhat between these two groups. In acute vestibular syndrome patients without nystagmus, the head impulse test has not been validated. Therefore, in this group, other elements of the examination, namely focused neurologic examination and gait testing, are more important. For a combination of all these reasons, I ask 5 sequential questions that incorporate hints but add 2 additional components in an attempt to maximize patient safety. So essentially, there's 2 types of dizziness patients that you can apply the hints exam to, right? So how to interpret the hints exam in the dizzy patient presenting with nystagmus? So the patient with a peripheral vertigo must have all 3 of these exams positive. Okay, number 1, the head impulse test has to be positive, meaning that there is a corrective saccade, right? Number 2, it has to be unidirectional nystagmus, fast component only going towards one side and does not change. So unidirectional horizontal nystagmus. And then it has to have a negative test of skew. So there's no vertical or medial or any sort of correction when you perform the test of skew. In a dizzy patient presenting with nystagmus, the central etiology of vertigo is indicated by one or more of the following, which is number 1, if the patient has no corrective saccade. We talked about that a couple of times. If the patient has no corrective saccade in the setting of a dizzy patient with nystagmus, then that is a central etiology until proven otherwise, right? Number 2, if they have bidirectional or direction changing horizontal nystagmus or pure torsional nystagmus or vertical nystagmus, that means a central etiology. And then if they have a positive test of skew. So any of these indicates a central etiology.
So you only need one to make it central etiology, but you need all 3 to say this is peripheral.
Right, exactly. So then Dr. Edlow makes the point of the second group, which is the acute dizzy patient without any nystagmus. So one of my patients was like that, and the other one was the dizzy patient. Right. So Dr. Edlow has an acute onset persistent dizziness diagnostic algorithm. We're not going to go through the details of it, but essentially he's asking these 5 questions, and that helps him catch all of those patients that potentially have central etiologies. So the first question is there a central pattern of that nystagmus? We talked about the bidirectional, that's a central pattern. Is skew deviation present? That's, if it is, it's a central etiology. Is the head impulse test negative, meaning that there is no corrective saccade? That's a central etiology. Are there any CNS signs on a focused neurologic exam? And I'll show you there's a chart for that. If there's any CNS signs on a focused neurologic exam, that's a central etiology. Is the patient unable to sit or walk unassisted? That oftentimes will tell you that it's central if they cannot walk, if they're very ataxic. So in his article, there's a nice table that talks about the focused neurologic exam. And these make sense if you look through the individual items, such as, if they have hearing loss, they have diplopia, if they have ptosis, anisocoria, if they have some facial weakness or paresthesias, if they have hoarseness, if they have limb ataxia, finger to nose, that kind of a thing, truncal ataxia or gait ataxia. These are all very much suggestive of central etiology. So if the patient has any of these, then they're not considered peripheral etiology for the dizziness, right?
The hearing rub is one that's tough with our population as well, because most of them are deaf. So
that is true.
If you ever hear me yelling in the emergency department, it's not because there's an emergency, it's because I have a deaf patient.
Right.
You make me
All right. Well, Dr. Patterson, I had some goals today. Hopefully, we've reached these goals. Number 1, know your hints exam. Know the actual technique to how to perform the head impulse the nystagmus exam and the test of skew, okay? Number 2, I wanted to teach us when we should use the hints. When should we use the hints, Dr. Patterson?
When they have continuing ongoing symptoms, not when they're asymptomatic.
That's right. Very excellent. And then lastly, I wanted to attempt to teach us how to interpret the hints exam, because it is more complex than just learning the actual physical task of examining a patient with the hints exam. So thank you so much, Dr. Patterson, for stopping by.
I think it was a great success.
You think? Reached my goal? Excellent. I think that really, I mean, the initial article came out 10 years ago. And it's the knowledge translation into the community is very, very slow. I am bound and determined through this screencast to teach ER doctors how to perform the hints exam. I'm going to incorporate it into my everyday practice as well. I think that the old traditional teaching of what type of dizziness is just wrong. Dr. Edlow says that in his article. Is it a spinning dizziness? Is it a fainting? And I asked those exact questions for decades. And now I actually have to have a paradigm shift in my own mind, the way I approach my dizzy patients, and that we have to consider using the hints exam to differentiate between peripheral and central. Well, thanks everybody for watching again this month. I hope to see you guys all at a conference coming up soon this year. So take care. Thanks for supporting me. Bye.
Bye.